Dr. Baliga here. Today's podcast is on COVID math for the physician. One measure of viral spread is the R naught. What is the R naught? It is the expected number of secondary infectious cases produced by a primary infectious case. That is, it's the pathogen's basic reproduction number and represents the number of new infections caused on an average by a single contagious person. This calculation is used to determine the potential for epidemic spread in a susceptible population. That is, it anticipates a worst case scenario that assumes the entire population is susceptible, well mixed, and taking no precautions to mitigate the spread of this COVID pandemic. So it tells us how bad it could really be and allows planning and preparedness. The Imperial College in London has epidemiologists who estimate the R naught for the COVID-19 virus to be somewhere between 1.5 to 3.5. R naught is hard to measure, but when it's below 1, wherever the number of cases is going down, and is above 1, wherever the number of cases is going up. And what may appear to be a small difference in R naught leads to a very large change. That is, if you started with 100 infections in the community, after 40 days you would end up with 17 infections at the lower rate and 3,200 cases at the higher rate. If every infection goes from causing 2 cases to only causing 0.7 infections, then after 40 days, there are only 1/6 as many infections instead of 32 as many. That's 192 times fewer cases. Another way to look at it is if there were 100 infections in a community, after 40 days, you would end up with 17 infections at the lower R naught and 3,200 at the higher one. Experts continue to debate just how long to keep R naught very low to drive down the number of cases before opening up begins. Simply put, when the R naught or the pathogen's basic reproduction number is less than 1, the pandemic won't proceed. When the number is greater than 1, the outbreak has the potential to grow exponentially until it reaches pandemic proportions. Another important measure is RT, which is the effective reproduction number. RT determines the potential for the epidemic spread at a specific time t under the control measures in place. To evaluate the effectiveness of public health interventions, the RT should be quantified in different settings, ideally at regular and frequent intervals, for example, weekly. The RT, or the effective reproduction number, is defined as the mean number of secondary cases generated by a typical primary case at time t in the population, calculated for the whole period over a 5-day moving average. In one study in the JAMA, where the authors from Wuhan report an RT of 3 to 4. In other words, each case spread to an average of 3 to 4 others. This is a striking number. Compare it to the RT of 1.4 to 1.7 for influenza, which is a disease that spreads widely around the world every year. Coupled with the fact that each new generation of COVID-2 cases occurs every 5 days, it is quite clear how this pandemic was spreading out of control. When all the measures in Wuhan, that is the lockdown in Wuhan, which included business closures, school closures, cancellation of gatherings, that is substantially lowering social interaction, became a part of day-to-day life, the RT of the epidemic declined to below 1 within weeks. When an RT decreases below 1 for a given disease in a given place, disease spread slows and the epidemic has potential to be controlled in that area. The US CDC should regularly report on RT for the US and for each of the 50 states so that governmental leaders can gauge how well the combined organizational and individual social distancing measures in the country are working to diminish the transmission of this virus. Transparency is needed for this data. Recommended reading: Public Health Measures and the Reproduction Number of SARS-CoV-2, published in JAMA May 1, 2020, authored by Thomas V. Inglesby, MD, from Johns Hopkins. There are several challenges with R0. R0 is affected by numerous biological, socio-behavioral, and environmental factors that govern pathogen transmission, and therefore is usually estimated with various types of complex mathematical models, which makes R0 easily misrepresented, misinterpreted, and misapplied. R0 is not a biological constant for a pathogen, a rate over time, or a measure of disease severity, and R0 cannot be modified through vaccination campaigns. R0 is rarely measured directly, and modeled R0 values are dependent on model structures and assumptions. Some R0 values reported in the scientific literature are likely obsolete. R0 must be estimated, reported, and applied with great caution because this basic metric is far from simple. Say authors in the CDC website. The authors in a article titled Complexity of the Basic Reproduction Number R0 are Paul Delmater, Erica Street, Timothy Leslie, Tony Yang, and Catherine Jacobson from UNC Chapel Hill. So R0 is not a simple number because the interpretation of R0 estimates derived from different models requires an understanding of the model structures, inputs, and interactions. Because many investigators using R0 have not been trained in sophisticated mathematical techniques, R0 is easily subject to misrepresentation, misinterpretation, and misapplication. R, or the effective reproduction rate, is calculated by 1 minus p into R0, where p is the proportion of the population that is immune. The challenge with this estimate is in the middle of a pandemic, it's difficult to estimate how many people are immune. One simple formula for estimating the percentage of the population that needs to be immune to achieve herd immunity is 1 minus 1 divided by R0. With an R0 of 2.5, the result would be 60%. Another important math or reference point is the herd immunity threshold. Herd immunity refers to the indirect protection offered to people who are susceptible to a disease but unlikely to get infected because enough people are immune that transmissions have slowed or stopped. Under usual circumstances, the threshold is used as a target for immunization coverage with the goal of protecting the population before a deadly virus has the opportunity to take off. Simply put, the herd immunity threshold is about preventing outbreaks. It is not a predictor of when the outbreak will end. Again, herd immunity refers to the indirect protection afforded to people who are susceptible to a disease but unlikely to get infected because enough people are immune that transmissions have slowed or stopped. Herd immunity threshold is about stopping the wave from ever taking off. The next math number in the COVID math is the true death rate for COVID-19. Determining mortality rates or death rates is particularly challenging in the midst of a pandemic where figures are necessarily fluid. Fatality rates based on comparing deaths which are relatively easy to count to infections which are not almost certainly overestimate the true lethality of the virus. Health officials and epidemiologists have estimated there are 5 to 10 people with undetected infection for every confirmed case in some communities. At least one estimate suggests there are far more. The big challenge to know the fatality rate, one needs to know how many people are infected and how many people died from the disease. We know how many people are dying, but we don't know how many people are infected. In fact, one could argue even the number of people dying is a moving target. COVID-19 deaths happen at home and appear to be widely underreported. But the missing data on deaths, the deaths to infection ratio is almost certainly to be dwarfed by an expected increase in the denominator when the total number of infections is better understood. Epidemiologists call it the severity bias. It is why the fatality rate in Wuhan, China, where the outbreak began, was initially reported to be between 2% and 3.4%, but later was revised to 1.4%, and it may be lower once the population is tested and the number of people actually infected and asymptomatic are known. There are two important measures one needs to know. One is the case fatality rate and one is the infection fatality rate. For example, in the cruise ship affected by the COVID-19, the ship's case fatality rate, which included only those who showed symptoms, was 2.6%, according to a study from the London School of Hygiene and Tropical Medicine, while the infection fatality rate, which included those who tested positive yet remained asymptomatic, was 1.3%. It is important to monitor the infection fatality rate closely because even a seemingly trivial decrease, for example, from 1% to 0.9%, could mean a few 100,000 fewer deaths in a population in the size of India or the United States. It can be also used to calibrate interventions aimed at preventing more deaths and their accompanying grim economic consequences. Just as a reference point, seasonal flu kills tens of thousands of Americans each year, and the infection fatality rate of seasonal flu strains is about 0.1%, and therefore it is important a small move in the needle of the infection fatality rate can have huge consequences. As parts of the US edge towards reopening, cases are rising in different states, and it is the virus's transmission rate as much as the infection fatality rate that is uppermost in the mind of public health experts trying to find a way forward. Finally, an important math of COVID is whether the curve has flattened. The Johns Hopkins Coronavirus Resource Center uses a 5-day moving average to visualize the number of new COVID-19 cases and calculates the rate of change. This is calculated for each day by averaging the values of that day, the 2 days before, and the next 2 days. This approach helps prevent major events such as changes in reporting methods for skewing the data. Interactive charts are shown at the Johns Hopkins Coronavirus Resource Center for the 10 most affected countries based on the number of deaths for COVID-19. The 10 most affected countries are US, Belgium, UK, Germany, Italy, Iran, France, Canada, Spain, and Brazil.